pleasure to be here. I was just reflecting with Professor Yellen that I had given a talk at a similar meeting just a few years ago, just as this field was sort of just starting to warm up. So really a lot of interesting information since then. So these are my financial disclosures. I do have one further disclaimer, which is that I'm not an endocrinologist or a diabetologist, although I am married to one. So I've had lots of good education around the dinner table and such. So I thought that I would spend the next about 30 minutes or so talking a little bit about how we got here, which was really a paradigm shift in diabetes drug development. Review with you the major SGLT2 outcomes trials, and I will focus somewhat on DECLARE-TIMI 58, which was the most recently published and one that I played a leadership role in. Talk with you about a meta-analysis of the SGLT2 inhibitors that we published recently in The Lancet. A little bit of a preview about what's next in discovery in this area, and then some about the clinical implications. So this is a slide that some of you may have seen before, but this is an epidemiologic study from the Swedish National Diabetes Register. And what this shows, it's a complicated slide, but what it shows is the hazard ratio for an increase in myocardial infarction based on your age stratum and the number of uncontrolled cardiovascular risk factors that you have. Here listed blood pressure, LDL, hemoglobin A1C, tobacco, and albuminuria. And if you see that for the myocardial infarction, when you get down to no uncontrolled risk factors, for patients with diabetes compared to those without, there really isn't an excess in myocardial infarction. Now, to contrast this with heart failure, we can see that even among those patients who have fully controlled cardiovascular risk factors, the likelihood of having heart failure events in patients with diabetes ranges from 1.5 to 2.5 fold. And as you move down the slide toward patients with multiple uncontrolled risk factors, you get into numbers, hazard ratios like 6, 10, and 11. So I think this is a good reminder that not only is, from a cardiovascular standpoint, is atherosclerotic cardiovascular disease, MI, and stroke increase with diabetes, but also heart failure is a major issue. I thought I would take just a couple of minutes and talk about how we got here to having these large cardiovascular outcomes trials to talk about. Back about 10 years ago, in order for a diabetes drug to be developed, this was the International Committee on Harmonization guidelines. 1,500 patients exposed total, 300 to 600 for 6 months, 100 for a year. So approval of a diabetes drug could be based on as little as 200 patient years of exposure. And then I think you'll all remember the meta-analytic data that was presented related to rosiglitazone. And I put in red the meta-analysis that was in the New England Journal of Medicine from Steve Nissen, showing a suggestion of an increase in myocardial infarction for patients taking rosiglitazone. And subsequently, there have been some questions about the statistical validity of these observations. But nonetheless, this, I think many of you in the room will remember, caused a bit of an earthquake in the diabetes area and led to many regulators discussing whether we need to develop additional guidelines. And indeed, what happened was, starting in 2008, there began a process where we had to demonstrate the cardiovascular safety of diabetes drugs in order for them to be on the market. And this was a two-step approval process where basically they had to demonstrate their ability to lower blood sugar, improve hemoglobin A1C, and really show that there wasn't an enormous excess of cardiovascular events, an upper bound of the confidence interval of less than 1.8. But then after the drugs were approved and being able to be used, then additional studies had to be done to narrow that confidence interval. And so what this resulted in is larger scale cardiovascular outcomes studies. And so this here shows if a drug had a neutral effect, no effect on cardiovascular events, you would need 122 events to demonstrate the first cut point of 1.8, but you'd need more than 600 events to demonstrate the cut point of 1.3. So this ushered in this era of the last decade of these cardiovascular mega trials in diabetes. And you can see here what this did in terms of our ability to study these medications. This is from Rory Holman, and you can see right around 2008, from going back 2 decades, there was probably on the order of 15 or 20,000 patients who had been studied across all of the diabetes agents. And then there was this inflection point related to the changes in regulation that led to about 10 times the number of those patients being studied over the period of the next 5 to 7 years. And so what this resulted in was this very large flood of cardiovascular outcomes trials. And this is an attempt here to show many of the major cardiovascular outcomes trials. This is color-coded by the type of drug, where, for instance, the PPARs are in gray, the DPP4s are in orange. Those came first. And then what we'll focus on here is the SGLT2 inhibitor trials in the light blue. And so you can see here, largely the first ones were EMPA-REG, then CANVAS, and so forth. So I'm going to review next the 3 large SGLT2 inhibitor trials in turn. And so this slide will serve to give you a little bit of background as to how these trials differ in terms of their populations. The EMPA-REG outcomes trial was 100% of patients had secondary prevention, meaning they had pre-existing atherosclerotic vascular disease, whether that be coronary disease, cerebrovascular disease, or peripheral artery disease. The CANVAS program was a mixed trial. About 2/3 of the patients were secondary prevention, about 1/3 with primary prevention. And then the DECLARE trial was essentially the opposite of that. About 2/3 of the patients, primary prevention, and about 40% here were secondary prevention. So a gradient of risk from highest risk to lowest risk presented in turn. So the EMPA-REG outcomes trial, which you can see here, published in 2015, I think was really in many cases a bit of a surprise. Although, as I mentioned, I think that people created these trials with the idea of demonstrating benefit. They were really designed and powered to show cardiovascular safety. And so when the EMPA-REG outcomes trial was published and presented, showing a modest reduction in MACE, a significant reduction in cardiovascular mortality, and a significant reduction in hospitalization for heart failure, this really, I think, changed the game in terms of the way that we think about our diabetes therapies. So we went from a mandate to demonstrate safety to this first trial showing really quite significant efficacy. But I think many people seeing a single trial, modestly sized trial, remained quite skeptical about these results and wondered whether this was, in some senses, a fortunate play of chance. When we look at the components of what was seen in the EMPA-REG outcomes trial, we can see that, again, there was a modest reduction in MACE, about a 14% reduction. That, interestingly, was largely driven by cardiovascular death, where non-fatal myocardial infarction, about a 13% reduction, and non-fatal stroke actually went the opposite direction, although not statistically significant, higher in the patients receiving empagliflozin than those patients receiving placebo. So this is one of the things that we sometimes see with composite outcomes. We're looking at the primary endpoint, which is the composite of the 3, but the drug's effect on the 3 different outcomes was quite different. So that was the data we had on SGLT2 inhibitors until the presentation 2 years later of the CANVAS trial. Again, I mentioned to you that CANVAS is mixed primary and secondary prevention. Now, interestingly, for the MACE outcome in this trial, cardiovascular death, non-fatal MI, non-fatal stroke, actually the same exact hazard ratio, 0.86, highly statistically significant for non-inferiority, just met the guidance for superiority. But interestingly, also, as was seen here, similarly to the EMPA-REG outcome study, a greater benefit was seen in the reduction of cardiovascular death and hospitalization for heart failure. But not everything came up roses in this study. We did see unexpectedly an increase in lower extremity amputations with canagliflozin compared to placebo. And I think that in many ways, although there has been some uncertainty about the mechanisms of this finding and whether this would be reproducible, this has held back, in many cases, the use of SGLT2 inhibitors. So this led us to our trial, the DECLARE-TIMI 58 trial. And so I'll take you through this one in a little bit more detail. This was just presented and published at the American Heart Association meeting in November, just a few weeks ago. And so this was the largest of the SGLT2 inhibitor trials. We had 17,100 plus patients with type 2 diabetes. They had either established cardiovascular disease, a secondary prevention population, or multiple risk factors, a primary prevention population. And what that meant essentially is that these were patients who had diabetes, were aged 55 for women, 60 for men, and then had any of the following risk factors. They either had hypertension, dyslipidemia, or were current smokers. So they didn't have to have multiple of those, just one additional risk factor. They were randomized then to dapagliflozin or placebo. We had designed this as a superiority trial, so that meant rather than 600 MACE events, we anticipated more than 1,300 MACE events. Patients were followed every 6 months in person for a median of 4.2 years. The analysis was done safety first, so we looked at MACE for the outcome of the upper bound of the confidence interval being 1.3. And then we had two co-primary endpoints, cardiovascular death and hospitalization for heart failure. And that was in part based on the results of the EMPA-REG study showing that heart failure seemed to be the greatest benefit. And then also MACE as a co-primary endpoint. And so these were our baseline characteristics. They're largely what you might expect in a mixed population of patients with diabetes. We had about a third women in this trial. The duration of diabetes median was 11 years. Hemoglobin A1C was, the mean was 8.3, although patients could come into the trial as low as 6.5 or as high as 12. Interestingly, the renal function in this trial was essentially normal. I think this is potentially a key difference between the three trials. You can see where patients were enrolled, and as I mentioned, the majority of patients were a primary prevention population, and about 10% of the patients in the trial had a history of heart failure. So these are the results in terms of some of the cardiovascular risk factors, and these look very similar to the other SGLT2 inhibitor trials, and in fact even the trials in development. So you can see that there was a rapid reduction in hemoglobin A1C. It was about 0.7 at the beginning. As is the case with all of the cardiovascular outcomes trials in diabetes, these are not really blood sugar lowering trials, right? People have the ability to change their background therapy. So over time, the hemoglobin A1C tends to come together. So it really is a trial of being on the drug or not being on the drug as opposed to specifically glucose lowering. On the right, as undoubtedly you've heard in terms of mechanisms of SGLT2 inhibitors, there was weight loss. This is not just fluid loss, but appears to be Also visceral fat loss associated with glucose calories lost in the urine, about 2 kilograms that was persistent throughout the trial. Systolic and diastolic blood pressure were both lower throughout the entire 4-year follow-up period. And so what we found in terms of our primary outcomes, as I mentioned, there were dual primary outcomes on the left, cardiovascular death and hospitalization for heart failure. This was 5.8 versus 4.9%. Lower rates, about half the rate of outcomes seen in the EMPA-REG trial. And the hazard ratio was 0.83, a 17% relative risk reduction, clearly met the superiority boundary of less than 0.025 for half of the alpha. On the right is MACE. We can see a hazard ratio of 0.93. The upper bound of the confidence interval is 1.03, which is certainly much less than the 1.3, and the non-inferiority bound was highly statistically significant. Did not meet the superiority boundary formally. So at this point, in terms of the statistical hierarchy, the testing would stop and the secondary outcomes would be considered to be hypothesis generating. These are those secondary endpoints. You can see that there's a renal composite on the left. This could perhaps better be termed a cardiorenal composite because it includes reduction in EGFR, ESRD, and then either renal or cardiovascular death. This was reduced by 24% nominally with a p-value less than 0.001. All-cause mortality numerically but not statistically lower. And here we look at the specific components of the endpoints. The primary and secondary endpoints are at the top. In the red are the components. You can see that the major benefit was related to hospitalization for heart failure and the core renal outcomes at the bottom. You can see that's reduced by 47%. There was a tendency toward a lower rate of myocardial infarction, no difference in stroke, no difference in cardiovascular death. So one of the interesting things that comes from DECLARE is that we had, for the first time, large populations of patients who were both primary and secondary prevention. And so we were able to look at the outcomes stratified by that. And so here, atherosclerotic cardiovascular disease, this is secondary prevention, patients with diabetes and already had vascular disease. Multiple risk factors are those without evident vascular disease. At the top here, we see for cardiovascular death and hospitalization for heart failure, very consistent outcomes, hazard ratio 0.83, 0.84, p-value of interaction 0.99. On the bottom, for the MACE outcomes, we can see a tendency that there's something different going on here. Now, we're not powered for that interaction, and the interaction term formally is neutral, but absolutely no difference in patients without established cardiovascular disease. Now, in terms of heart failure, this was a little bit different. These are the outcomes for cardiovascular death and hospitalization for heart failure. If you look at heart failure alone, even more dramatic, really consistent reduction regardless of prior atherosclerotic disease, consistent reductions regardless of baseline heart failure. So in some senses, you could think of them in the red box, treatment of patients with heart failure, reducing the likelihood of being rehospitalized with heart failure, or prevention of heart failure. So patients who don't have evident heart failure not having their first hospitalization. At the bottom, again, no statistical interaction, but a suggestion that there may be a greater effect in patients who have impaired kidney function. So one of the key things that comes from DECLARE, again, is a very large trial, so the opportunity to look at safety events in some significant detail. And so the way we had listed several key safety outcomes prior to closing out the trial related to mechanism of drug and prior trial results. And so here, the way that we've organized this slide is that in green, the p-values indicate those events that had lower rates with dapagliflozin. In red are the p-values for events that had higher rates with dapagliflozin. and in the black are those that were neutral. And so, I think the key pieces here from the lower standpoint, overall emergent treatment emergent events were lower. So this is unusual. This is, suggests that overall there were fewer events of any type, safety events that occurred with dapagliflozin compared to placebo. Major hypoglycemia was lower. I think this probably owes to the changes in background therapies being greater in the other arm, and the fact that SGLT2s are often called euglycemic because the amount of glucose lowering is based on the amount of glucose delivered to the kidney. Acute kidney injury was lower. We'll talk a little bit more about kidney outcomes in a bit. And bladder cancer, which had been something that had been raised previously as a potential concern, was not seen to be elevated. In terms of the risks, we did see more patients who stopped study drug because of events. That was almost entirely driven by an increase in genital infections, which is, I think, to everybody in the room, a common side effect of the SGLT2 inhibitors. Diabetic ketoacidosis was also higher, although the rates were low. Now, importantly, we did not see in our overall population an increase in amputation, an increase in fracture, or symptoms of volume depletion, which had been some things that had been raised from previous studies. So summarizing what we had from DECLARE, which was the largest SGLT2 inhibitor trial, included a broad representation of primary and secondary prevention patients. We concluded in our presentation and in our paper that dapagliflozin reduced cardiovascular death and hospitalization for heart failure, was safe with regard to MACE, and appeared to reduce renal events. This reduction in heart failure was consistent regardless of baseline atherosclerotic disease. We also felt that it was safe and well tolerated. There were increases in genital infections and diabetic ketoacidosis, but we did not see concerns related to amputation, fracture, or stroke. So one of the things that we had the opportunity to do at the time of our presentation was, because the previous studies had already been published, was to meta-analyze the 3 SGLT2 inhibitor trials to see if we could come up with some consistent patterns across the different studies. And so we often say in publication it's better to either be first or to be last, because if you're last, you're the only one that has all the data while it's still blinded. Nobody laughs at that when I say that. But nonetheless, we did, this was led by Thomas Elnicker, who's an outstanding fellow with us, Mark Sabatine, who's our chairman. But so we had an opportunity to really look and examine the 3 trials in some detail. And you can see here that Canvas was the shortest of the 3, DECLARE was the longest. DECLARE was the largest, accompanying about the same number of patients that were seen in the other 2 trials. Ages were similar, female sex was similar, and I've already highlighted the differences in the primary and secondary prevention populations. Heart failure, again, seen in 10 to 15% of the subjects. One thing that was quite different, though, was the kidney function, which is shown here, that in patients in EMPA-REG, about 26% had EGFR less than 60, compared to DECLARE, where patients had EGFR less than 60 was only about 7%. And in fact, we used creatinine clearance as the enrollment, and it had to be above 60 for creatinine clearance. So that 7% is really the difference between the calculations of creatinine clearance and EGFR. So most of those patients would have an EGFR in the high 50s. So this is the meta-analysis of the primary MACE outcomes. One thing to point out here, again, is the differences in the populations. Placebo events per 1,000 patient years differed almost twofold among the 3 trials. But interestingly, you can see at the bottom, for people who aren't particularly familiar with meta-analysis, the I-squared tells you a little bit about the heterogeneity among the 3 trials, and the I-squared of 0.00 suggests that for the MACE outcomes overall, that these are all quite quite consistent. And so we can see meta-analyzed in the overall populations about a 10%, 11% reduction in MACE. Now, interestingly, as I had alluded to in DECLARE, when we divide this by the presence of atherosclerosis, primary versus secondary prevention, we do see that this pattern tends to hold, and that patients with established atherosclerosis had about a 14% relative reduction in recurrent events, whereas those without atherosclerosis had no difference. And this actually met a statistical heterogeneity with a p-value of 0.05. Whereas the heart failure outcomes, again, were quite consistent regardless of whether patients had atherosclerotic disease or not. So you can see at the top those patients, which we would call secondary prevention patients, a 29% reduction in hospitalization for heart failure. And in fact, the patients without pre-existing atherosclerosis had an even greater reduction in hospitalization for heart failure. So it seems that the heart failure outcomes are relatively consistent regardless of background. And in fact, here, if we look at hospitalization for heart failure based on whether patients had heart failure at baseline or not, so this is, again, this concept of prevention of heart failure versus treatment of heart failure. And you can see the event rates are quite different. If you focus, for instance, on EMPA-REG, in the placebo group, for those who had a history of heart failure, the heart failure event rate was 5 times higher than it was for patients without. If you look at DECLARE, 7 times higher. So this isn't to say that the risk of heart failure is the same, but the drugs seem to reduce either recurrence of heart failure or first heart failure event with some consistency. Again, looking at some of the risks associated with SGLT2 inhibitors, here this is meta-analysis of amputations. Overall, a modest increase, 1.26, which met statistical significance. Although, as I pointed out to you before, the I-square value, which was 0 for the major outcome, is quite high here, suggesting that there is some difference between these trials. And much of this, as you can see, is driven by the difference in canvas. Diabetic ketoacidosis. Really quite consistent. There does appear to be something like a doubling in the risk of diabetic ketoacidosis, although the number of events is quite low. Remember, we talked about 50 heart failure events per 1,000 patient years in EMPA-REG, whereas we're talking about, overall here about 0.3 or 0.4 events per 1,000 patient years for diabetic ketoacidosis. So, somewhere on the order of 250 times less likely. So conclusions based on this meta-analysis with the 3 large cardiovascular outcomes trials, I think what we feel are the commonalities here is that SGLT2 inhibitors seem to have moderate benefits on atherosclerotic MACE, and these benefits do appear to be confined to those patients with established atherosclerosis. We can talk in the discussion about why that might be. And I think many people wonder whether that is related to the duration of these studies, that if we followed patients longer, whether we might see these benefits, but we haven't seen them to date. They do have robust effects in reducing the risk of heart failure and renal outcomes, which don't appear dependent on baseline atherosclerotic risk or prior heart failure. So this is this was a editorial that was first authored by Subodh Verma that accompanied our meta-analysis in The Lancet. And I think it's a nice sort of conceptual way to think about what we've seen in terms of the cardiovascular benefits of the SGLT2 inhibitors. And so you can look at the top of the pyramid, or the sort of tip of the iceberg here, is patients with diabetes and established cardiovascular disease. And in those patients, there seems to be a reduction in atherosclerotic events, reductions in MACE, reductions in heart failure, and renal protection. Below that group is a much larger population of patients who have diabetes who do not have yet established cardiovascular disease. And in those patients, the benefits seem to be largely related to hospitalization for heart failure and renal protection. So just a quick run through of what's next in this area, and then I'll sum up. So, I think in many ways when this whole field began, again, a lot of these trials were driven by regulatory requirements to show safety, and we've now demonstrated efficacy. And so many people have started to think about what are the mechanisms that underlie this. And I know you had a discussion about this already this morning. But I would say that the next phase in the evaluation of the SGLT2 inhibitors is looking at patients both with and without diabetes. Many of the ongoing trials are in patients with prediabetes or in patients who have normal glycemia. And listed here on the slide are some soft reasons as to think why there might be continued benefit among patients without diabetes. The next wave of SGLT2 inhibitor trials, and this is not meant to be a comprehensive list, but to show you a little bit about what's going on, will be in heart failure. We will see in the next couple of years reporting out trials with heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, and acute heart failure trials. And there is also a large number of trials and a great deal of interest in looking at the SGLT2 inhibitors for renal protection. And so I'll close here with what some of the clinical implications of these diabetes cardiovascular outcomes trials are, and particularly focusing on the SGLT2 inhibitors. So I'm sure many of you have seen that the ADA and the EASD released their 2018 consensus for glucose-lowering medications, their update on how we should be thinking about treatments for diabetes. And so as is always been the case, first-line therapy is metformin, first-line therapy is comprehensive lifestyle management. And then if there continues to be a need for glucose-lowering therapy and there's established atherosclerotic disease or cardiovascular disease, they now separate this group as a special group. And I'll dig deeper into this in a moment. And then that's really the first question that people are now asking is there established disease or not? And how do we think about our therapies? And so digging in here, we see that in cases where atherosclerotic disease predominates, they recommend either a GLP-1 or an SGLT2, particularly in this case if there's appropriate renal function based on the approval of these drugs. And then on the right-hand side here, if heart failure or chronic kidney disease predominates, recommendation for the use of an SGLT2. And so, interestingly, I think one of the key messages from DECLARE is that there seems to be benefits, particularly for heart failure and renal protection in patients who don't have established cardiovascular disease. So the question that we would raise is, should this now be broadened? Should we be thinking about the use of these agents in a broader population, not just those who have established disease? So just to summarize finally, patients with diabetes are high risk for ischemic events, heart failure, CKD. These are three sets of conditions which act synergistically to increase disability and mortality. As I started with, a change in the regulatory guidance stimulated a new era of these cardiovascular megatrials from which we have strong evidence for the benefit in two classes of agents, the GLP-1s, which I didn't discuss, and the SGLT2s, which prevent heart failure, CKD, and at least have a modest effect on atherosclerosis. And the ongoing studies that I've shown you are evaluating these agents for heart failure, CKD treatments in patients with and without diabetes. So I'll stop there and happy to entertain discussion or take questions.